Hi, and
Hello.
welcome, welcome to old. I was going to say old Yatna. That's not very nice, is it?
I'm not old, Katrina.
Lovely.
I'm only turning 35 next week. Only 35.
Only 35.
Only.
Oh God, it's my
Already, or the bones in the joints are already aching.
Oh well, I tell you what, it's my big birthday in 2 weeks' time.
Well, you only look 21.
No, it's one with a 0 on it, so should we go for 30?
You don't look a day over 25.
Oh, you're very kind. Anyway, today we are going to be talking, obviously, feet, because Yatna is you're almost our in-house podiatrist.
I am.
Right, aren't you? So, and because hopefully some of you will have already seen that we're running arthritis clinic in January. And even if you watch this webinar in the summer, whenever, you can also go and have a look, because our arthritis clinic will be up. We've got some great professionals there answering all kinds of questions. But today we're going to talk about feet and arthritis. Now, I don't know, it never sort of twigged, but I'm assuming why lots of old people, I say old people, and that's not fair, because it's absolute, arthritis doesn't hit just because you're old. But obviously it's one of those things that is more likely to happen when you're older, or is likely to happen, more likely to happen than not. That people are walking a bit funny, and presumably that's because of the pain in their feet from potentially arthritis.
Well, not even just their feet, Katrina. There's loads of different arthritises that you can get. But it's not just your feet you get arthritis in, it's the main joints, hip, shoulders, hips, knees, ankles.
My thumb.
Thumb, if you're overworking or spending too much money, counting too much money.
Yeah, as if.
I don't think anyone's got any money left after Christmas, have they?
No. So today, what we're going to talk about is feet and arthritis, and I think we've decided how to structure it because there's quite a lot of information which is specific, because there's rheumatoid arthritis and there's osteoarthritis, which are not the same.
No, they're not.
And so we need to treat them differently. So I think we're going to talk about the 4 main types of arthritis, what the symptoms are, what to look for, how to treat and manage them, and then the sort of general hints and tips around it.
Yeah? Yes.
So I think we're going to kick off with the most common, which is osteoarthritis.
Yeah.
So if you'd like to have just a general chat about what it is to start with, would be fab.
So osteoarthritis is a degenerative condition. So and it's more of a long-term condition. It's not a condition you have for a short while and then it goes. So it's wear and tear, basically. Simply, that is how we describe it. Wear and tear of the larger joints. It's not the tiny joints. It's your knees, your hips, your shoulders, because they're all weight-bearing joints. They're the joints that take on the load of our whole body. Okay. The ways that you can tell that you've got it is when you're starting to get quite stiff. Everyday activities are becoming harder. The main one is, and it sounds awful, the crunching of your joints, because what's predominantly happened is the cartilage between your big joints in the middle has worn away. So rather than getting that nice, soft, fluid in between your joints, helping you to bend, you've got the bones crushing against each other. Okay, and that's simply what osteoarthritis is. Really, really simple.
I find that when I walk up the stairs, I listen carefully, I can hear crackling in my knee. Do you think that's arthritis?
Oh, it could be joint space moving, but is it painful? If it's painful, honestly, it will feel like a crunching. You'll feel like you can feel it, and it will be painful. Osteoarthritis has pain attached to it.
No, I have it in my thumb. I've had it in my thumb for a long time, but touch wood, that's kind of where I have it. So, but I think in the feet it's quite common though, isn't it?
No. Osteoarthritis is mainly more common in the knees and the hips. Right. Obviously we're going to touch on this, but it's more common to have rheumatoid arthritis in the feet. But we'll go on to that because it's very, very different to osteoarthritis. And people always say, oh, I've got arthritis. or I've got rheumatoid arthritis, and like I said, go into that. You probably haven't. It's probably just osteoarthritis, and we're all getting older. Every day we're getting older, and a lot of us are doing more and more activity, or some of us at the other end are putting on weight, so putting more demand on these joints. So you have to think, every day we get older, every piece of our body, our ligaments, our tendons, the bones, everything gets a day older, and you can't get new ones unless you have surgery.
God, that sounds quite depressing, doesn't it?
I know, it's keep fit and put more weight on the joints, which can also help cause osteoarthritis, or don't do it and you end up eating too much and putting on weight and you still get it. But we're all going to have some degree of osteoarthritis as we get older, and you predominantly start getting it after about 45 mainly, but you can get it younger. Like I've got it, I know I've got it because I've been really active, so I know I've got a degree of it in my hips and my knees. I can hear it sometimes in my knees. So it just depends on lifestyle, health conditions,
Okay, so osteoarthritis, so do many people present in your clinic with osteoarthritis in their feet? And do they recognise, is it something that you would recognise that as being osteoarthritis yourself, or would you think, well, that's a funny pain?
No, it depends what you say to me. If you come into the clinic and go, oh yeah, no, I've got this like crunching sound in my knee, well, straight away, crunching is bone on bone. You don't get crunching from a torn cartilage. That's a totally different pain. So crunching is the key word if a person comes into my clinic, and where it is. If they were to say it was in my big toe, I wouldn't say, oh, that's actually osteoarthritis. I'd look into what that is. But yes, in the big toe, mainly you can get arthritis, what we call like hallux limitus and hallux rigidus, and then you get hard skin. So that's what I would be looking for if you came for a consultation with me, in the foot.
Okay, so with osteo, the symptoms to look out for: the crunching, crackling,
swelling, pain, crunching, swelling, and stiffness. So, getting up in the morning and it feels really stiff on the joints. And then, and getting painful whilst you're doing activity.
And then, but also you said hard skin. Why would you get hard skin from?
Because the joint's not functioning properly, so the biomechanics of your foot change. So let's just say your big toe, you're getting some arthritis in the big toe joint, which can look like a bunion. So you get extra bone growth on the knuckle of the big toe, and because you're not getting the motion there, because you've lost the cartilage, so the movement's changing, it stops. So the biomechanics, you stop the big toe joint moving as well as it did before, and it causes hard skin to build up as a protection.
Oh, right. Oh, okay. And then, so what do you then advise to manage that?
So obviously see a podiatrist regularly for the hard skin, because that can get more painful, which then can change how you walk, because you then unconsciously try to walk off that hard skin or that pain, which then could lead to your knees and to your hips and give you some imbalances, then leading to orthotics, insoles in your shoes to help redistribute that pressure, but keep it good foot care, moisturizing, taking that hard skin down, seeing a podiatrist. But to manage it, you can get creams, pain relief gels, ibuprofen gels, things like that. Obviously, if it's weight orientated, is increasing your level of activity to help reduce some of that load, body weight on those joints, losing weight.
Right. Okay. So is there anything, before we move on to rheumatoid, is there anything else to say, do you think, on osteo?
So I think suitable footwear, trainers, something with a good shock absorber. So a trainer with, so the shock absorption would be on the bottom. So I will show you on my trainer. So this is, a good, nice, thick-soled shoe. It doesn't have to be a trainer, but a shoe. This is what's going to suck up that impact from the ground. So you know how hard concrete is. Imagine walking barefoot. You know, I know people get these barefoot trainers, but we have evolved from caveman to humans, and we're not like cavemen, hence why we have shoes now. So if you are persuaded to buy these kind of barefoot trainers, if you think you've got arthritis, you shouldn't be getting those. You need this protection on the bottom, okay? Making sure obviously your trainers are nice and wide and nice and deep as well, so your feet can fit comfortably in there and you get that movement. Anything too narrow is going to obviously push the toes together and stick those joints out, and you get more hard skin. So footwear will play a big key role if you're getting, let's just say, knee osteoarthritis, because if you don't have that support, you're going to get more and more pain in those knees, because the impact's there and you're not getting any shock absorption from the ground reaction force.
And just looking at your sort of, I would call them running shoes, do runners suffer more from osteoarthritis in their feet than other people, do you think?
They can do, but not always, because there's things like osteoporosis. Like for females, after age of 35, we lose 1% of our bone density. But what research says is that if we do like weightlifting, for instance, or activities that do put impact on our joints, it increases the bone strength. But you need to be doing that from a younger age, as well as you can't just start at 60, let's just say, and then you'll increase, your bone strength. You need to. It's healthy to lift weights and put that tension on the joints and the bones, and that will actually help keep your bones strong. Vitamin D is very good for bones as well. We don't get enough sunlight in England. Even I take vitamin D. My doctor said that I needed to take it, and she said that everyone in England should be taking vitamin D3, and it's good for joints. And being a specialist that deals with a lot of older people, when I get their medication list from the GP, and a majority of older people over 60 are now being prescribed vitamin D from the GP. So that's a good tip actually I would give to people, is get on some vitamin D, different strengths. You could go, I take 1,000, I can't pronounce the measurements, like UIP, something like that, but I take 1,000, but in Asians, we do actually suffer more with low vitamin D, so that's why I take a higher dosage, but that was off the advice from my GP.
And in fairness, I think everybody that's come on that has, lots of conditions that we cover, most of the experts will say go on to vitamin D, and maybe in the summer you can lower it down, but otherwise you just kind of keep on it. So, and interesting enough, we did a webinar, I think it was this time last year, with a lovely lady, and she was just saying that how important it was to keep your bones strong. And whereas beforehand we thought, well, it was a natural thing of age, your bones deteriorate, yes, but it doesn't mean that they have to. If you're doing those weight things, you can keep up a very good level of bone density, which I think is really important. Yeah. Okay.
One other thing is that obviously you can have the last treatment, which is obviously in severe cases is surgery, knee replacements, hip replacements. I have seen some ankle replacements, but less common. But obviously if your knees or your hips are crunching too much, then you need a replacement.
Absolutely. And I think hip replacements are amazing now. They're very common. Knee replacements are still quite tricky ones.
Yes. And they're doing wonders now. They literally do the replacement, and in that day they get you up and walking.
But I think that's also indicative of how we view health, how it's changed. Whereas beforehand you were always in bed for a long time. Whatever has happened to you, however major the surgery you had, they get you up on your feet. And that's why feet are so important for your health, isn't it? It boils down. Okay, so moving on then to the rheumatoid arthritis, which I think, I think it's completely different. I think they call it a disease. It is a completely different disease from osteo, and it's something that people should definitely be on the lookout for.
Yeah, so I get a lot of people in clinic going, oh yeah, I've got rheumatism, or I've got arthritis, I've got rheumatoid arthritis. There was a big difference, a very big difference. So rheumatoid arthritis is an autoimmune disorder. So basically, the immune system doesn't work properly. And what it does, and it attacks the lining of the joints. So it's basically our immune system attacking ourselves. That doesn't happen in osteoarthritis. Okay, so it's actually the synovial fluid in the middle of all the joints, which is being attacked. So it causes inflammation. Okay. This normally actually happens in the smaller joints. So in the middle, these little joints of our fingers, and in our feet as well. And that's a more common one that I would see in clinic as people with rheumatoid arthritis. Yes, because it changes the foot shape. Your foot will change shape. You'll get more clawing of toes, more bunions, where the muscles, I'm going to use easy terms here, relax, so that the big toe normally goes over, and then you get underriding and overriding toes. You lose the fat pad moves up and it exposes the bones as such, so you feel like, and this is one of the osteoarthritis, you hear the crunching. With rheumatoid arthritis, the key that most of them will say is it feels like I'm walking on pebbles. Why? Because the metatarsals have been exposed, the fat pads moved up here, and they'll be walking on their bones basically, and they'll get hard skin building up on these areas because the pressure's increased in these areas. So that's how different rheumatoid arthritis and osteoarthritis is. With rheumatoid arthritis, there's the rheumatoid factor in the blood, and that's how you get diagnosed with it. You have to have a blood test, and it will get confirmed with the rheumatoid factor in your blood.
So going back to what we mentioned earlier, it's for rheumatoid arthritis, that quite often, is that the one where you often see it, it's the first place you see it, is quite often in the feet?
Yes, you can do, because you get the swelling of the joints, joint pain, and the foot starts to become a deformed shape, and you can do. But you can also, if you've got it in the family, there's a high chance of you having it. I remember treating a 35-year-old in my clinic. Okay, she came in and I just looked at her feet and her hands. It was more her hands actually, because you see a patient's hands, you see their feet in my clinic. And I just said to her, does anyone in your family have rheumatoid arthritis? And she says, yeah, my mum and dad. And I said, I think you need to get a blood test. I didn't even have to look at her feet, and I knew. So visually, you can spot rheumatoid arthritis before a patient even tells you their symptoms. Whereas osteoarthritis, you need to hear symptoms. You can't actually see it.
So if somebody presents with rheumatoid arthritis, are they generally coming in? They're not really coming in for a diagnosis. They're coming in for you to manage maybe the hard skin?
Yes. Yeah. So they're coming in because their feet hurt. Their feet they feel like they're walking on pebbles, and they're getting hard skin. Their toes are going over. So yeah, that's why they would come and see me. And then it's me as a clinician who would look at their feet and go, have you had a blood test? Has your GP considered that you might have rheumatoid arthritis? This is why they could be happening.
Mm-hmm. And then managing it moving forward.
Management for rheumatoid arthritis is actually quite, there's more to it than osteoarthritis. So first of all, there's medication. There's so many different types of medications. So you can get DMARDs, like methotrexate. They're called disease-modifying drugs. They all have side effects, and this is why I say you don't want to have rheumatoid arthritis. It's very difficult managing it because of the pain. Then there's also NSAIDs, so non-steroidal inflammatory drugs. They're your naproxens and ibuprofen. They help to reduce the swelling. It's not the same as paracetamol. Things like ibuprofen, because that's what most of us take if we've got a headache, all they do is mask the pain, so you can't feel it, but it's still happening. Okay. Whereas the DMARDs, the methotrexate, are actually trying to help the disease. And then you've got steroids, and these are all prescribed from your GP, apart from ibuprofen, but everything else is by the GP. So there will be some sort of medication attached to having rheumatoid arthritis to help you manage the condition.
Mm.
Maybe there's point in the pain.
Yeah, I mean, and obviously I'm certainly no expert, and then rheumatoid, you know, you're not a rheumatoid arthritis specialist either, other than in managing people's feet. But I do understand with rheumatoid arthritis that the sooner you get it diagnosed, the better for treatment. They flipped around, I think, from whereas beforehand they used to leave it longer before they started treating it. Now I think they're very keen to get people to treat it, to try to not, you can't obviously nip it in the bud, but yeah.
Well, I think it's like with anything, like even, you know, high blood pressure or like diabetes as well. Like the quicker you know that you've got it, you can start to make the changes in your life. You know, being healthy, trying to do a bit more activity, sorting your footwear out, getting a podiatrist to check your feet regularly, you know, checking your feet. Always spotting things earlier is much better than waiting, because once your foot's changed, it's changed. So people with rheumatoid arthritis I've seen, like some of my patients have had to have some of their feet have got so bad they've had their toes broken and pinned because they've just gone so over and crunched together that they've had to have them straightened, but then their toes are poked straight. You don't get the movement again from them. You know, a lot of people do end up having surgery with their feet and their hands mainly.
Yeah, gosh, which is really quite frightening. I mean, I know last time when you very kindly came on, we spoke about diabetes and feet. And I was speaking to somebody the other week, and they had no idea about the connection between diabetes and feet, which I found shocking. So, you know, but there's still a lot of education to be had for people. And I think, you know, one of the things that I came away from our last webinar was about how frightening it is that when you do start to manage it, you can't get your feet back to where they were, because the nerve damage has been done. And that was, I thought, gosh, that's quite an eye-opener.
Yeah, that's why early treatment is much better, or being aware of it earlier is much better. With rheumatoid as well, which actually, again, this is, I feel like, you know, I'm saying this is the worst arthritis to have, but it doesn't just affect your joints, it affects things like your eyes and your heart, your blood flow, and your lungs. So it's just what we call a systemic disease. It's not like osteoarthritis, just your knees and your hips and large joints. It affects your whole body. That's why when people come in, I say, oh, trust me, you don't have rheumatoid arthritis. So that's why early detection is much better than leaving it. So if you start to feel like your fingers, for instance, let's just say we all look at our hands more than we look at our feet. If you start to see them like swelling in the smaller joints, that would be an indication to go to your GP and say, look, my fingers have started swelling. And it's called, they look swan-like, like a swan neck. They go in like that. So looking at that and seeing that, you know, swelling on the joints and redness, your hands will look puffy, but like, as in like little, like Michelin Man, like that. There's early indications to go and get it checked out. Because like I said, it can affect other systems of your body. It's not just your joints. It's not just arthritis. It is serious. So get to your GP straight away if you start to get those symptoms.
And then the other one, the next one, moving on, is the one that lots of people joke about, and there's a lot of, you know, and it's absolutely not a joke, because I know that people have it, and it is a really, really rotten thing to have, which is gout.
Yeah. So gout is where you have the buildup of uric acid in the joints, and predominantly this happens in the big toe. I see gout being thrown around willy-nilly. Oh, you've got gout. Trust me, if you have gout, you don't want to have gout. So it's usually in the big toe, can be in other joints. It does present similar to rheumatoid arthritis. You know, you get hot, swollen joints, but it's always over a joint. It wouldn't just be randomly in the middle of your foot. It's on a joint. okay?
Right.
Because that's where the crystals build up in between the joint. And so a gout flare-up will last for about a week, 5 to 7 days. It's not something it's there, it's like a volcano. It can lie dormant, and then you suddenly get a flare-up, and it's painful.
And you can't walk, can you? I mean, I know
No.
that's absolutely, you cannot even hobble.
No, it does, again, like osteoarthritis, it feels like it's crunching in the bone, and it is not nice. You can get what we call toffee build up, so it looks like soft cheese, and it's called gout toffee, and it builds up in the joints. So as a podiatrist, and obviously I specialize in wound care, because it's an inflammatory arthritis, it can break open. And when it breaks open, it can get infected, which can then lead to a bone infection. So that's how bad it can get.
So what does it present as? So on your toe joint,
it will look like a beacon. It will be shining. It will be bright, and it'll be swollen. That's how you'll know it.
I think you'll notice.
Yeah, you would notice, and you'd feel the pain.
Yeah, and I think there's quite a lot of debate as to whether gout is caused by other medication and all of those things. I mean, it makes me laugh when you say it's one of those things you don't want to have. It makes it sound like you've got a choice. I think with a lot of these, you don't have a choice.
No, but there are some things, and I know I've said this quite a lot for all the arthritis is one of the things that can lead you towards it is being overweight, because the body has to produce more uric acid. So therefore, what's not happening is the uric acid is not being filtered out of the blood via the kidneys. Therefore, it builds up in your joints. So again, like I just mentioned, kidneys, it could lead to kidney stones and kidney problems. So
but I think the good news with the positive things is with all of these, you know, once you're aware of it, you can start managing them, which means that you can absolutely lessen your symptoms. Now, it could be that your symptoms can be severe still, but hopefully you can shorten the time in which you might be in a flare-up, for example.
Yes. So, doom and gloom. A good way to reduce your gout flare-ups, and if you do have gout, avoid red meat, shellfish, alcohol, especially beer. These all induce or can lead to flare-ups, and it can cause it to get worse. So everything in moderation, but I would say you should be reducing it, not moderation, reducing it in gout.
And is gout something that you see quite often?
Yeah. Mainly see it in men.
Yeah, and
other than women.
So when people come to you with gout, is it because they want you to treat the sores, or
no? It's normally they don't realise they've got gout.
Okay.
And then they're like, oh, my big toe's really painful, would you be able to have a look at it? And then I'll look at it, and they'd be like, oh, this looks like gout. And you can see this one, like I said, it's like a beacon. It's red, and it's swollen and inflamed. So you can see this one again, just like rheumatoid arthritis. That's why it's a differential diagnosis with RA.
Okay. And presumably, I don't know, is there any other tips that you would give, any footwear, or I suppose that you probably can't be able to get your foot into your...
So if you do have gout, then you need to, it's the same for majority of all these arthritis, not a good fitting shoe that's nice and deep, because remember, when your foot flares up, it gets bigger, it swells up, and if you've got a tight shoe on, like a ballet pump or a slip-on court shoe, it's going to put pressure on that area, and it'll be even more painful. It's changing your way of thinking of what shoes you're going to buy and wear. Nothing too restrictive, nothing too narrow, and avoid slip-on shoes.
Because the slip-on means that they can be wide and not supportive. Is that right?
Yes, and what happens is your feet will keep sliding, and your toes will have to grab to keep them on. And imagine if you've got gout in that big toe, that's going to be painful.
As a quick aside, before we go on to the last type of arthritis, when I was a young girl, we used to, to have shoes. We'd go into a shop, we would be fit, would be measured, would be fitted, and it was all, really important. Now that doesn't happen nowadays, and people have slip-on shoes. Have you seen a deterioration? That's almost said that right. Of people's feet, because presumably it doesn't necessarily happen straight away when they're younger, but as they get older, the effects of not having well-fitted shoes when you were younger.
So I think we're progressing, because obviously we don't get winkle pickers anymore. I hear that all the time. Trainers are so cool now, and people are actually looking after their feet a lot more. I think men's shoes are actually the ones that are getting worse, because they actually follow fashion and they care what there's on their feet, whereas back in the day, men used to wear good shoes. Now we've got all these narrow fitting, thin soled bottom dress shoes, which are this is why I see more men. But people are looking after their feet more.
So it sort of swings and roundabouts then, really.
Yeah.
But yes, and I suppose having trainers is good, because most trainers offer that a form of shock absorption.
Yes.
On
and then you've got the laces, which can help to adjust your foot. So like I always say, when we wake up, our feet are nice and skinny. As the day goes on, gravity pulls tissue fluid downwards. So if you're like me, who sits down quite a lot, and my ankles swell, I can see the sock mark around my ankle. You need a shoe that you can adjust. So like if your foot swells and you feel that tightness, you can undo the laces and just make it bigger. If you've got a slip-on shoe, that's not happening. And I don't know if you've seen the ladies when they're walking around town, they've got a slip-on shoe, and you can see it. You see the big bit of fat bulging over the shoe. That's what's happened. They're trying to squeeze a swollen foot into a small shoe.
I know, and it looks really uncomfortable, painful.
Yeah, painful.
Not great.
Edema, that's what we call it, like, so swollen ankles, it is painful. It feels like it's burning, and you get a fatigue feeling, like the feet feel tired, because they are.
Okay then, so moving on then to the last one. I don't know if it's the last one, but the last one that we're going to
I just wanted to talk about the treatment, the medication. There's medication with gout. Another way that it gets diagnosed is that you can go and get joint fluid tests, a blood test, because you'd have higher percentage of uric acid in the blood. Also with an x-ray, you can see it on an x-ray or an ultrasound. Not a lot of podiatrists do ultrasounds. You'd have to go by your GP, but privately there are some specialist podiatrists that offer ultrasound. But yeah, you can simply just get it diagnosed with a blood test. Okay. And then some of the medications that the GP can put you on is, so there's allopurinol, which is like you would take all the time, and that would help manage your gout so you don't have many flare-ups. But some people get flare-ups, and when you do, the GP can give you something called colchicine. So it's something that you would take for about 5 days, and that would help with your flare-up if you get them quite often. But yeah, allopurinol is one of the most common medications that you'd find someone with gout on, and that helps manage it, keeps it under control. Exercising regularly will help. Looking at your diet and reducing those foods that I said, red meat, shellfish, alcohol, that's all going to help with reducing gout flare-ups and it getting worse. There are steroids as well, but I will always be cautious when taking steroids. You shouldn't take steroids for a long period of time unless the GP gives them to you. Things like prednisolone, which would be prescribed, and you'd have to take for your rheumatoid arthritis. But yeah, you need to always be careful with steroid creams and anything with steroids in. You don't really want to be taking those long term.
No, I think, and we've done quite a few webinars where we discuss it, particularly for people who have got some skin conditions, is yes, there is a place for steroids as long as you manage using them correctly, you don't abuse them, and all of those things. But once again, there's so many things that you can do to improve it, and I think everybody knows gout and diet. I think there's lots of maybe false rumours, but there definitely is the link there between the two. And, it does sound like, it seems to always make sense, is what you feed your body makes such a difference to everything else.
Yeah.
So really important. Okay. So shall we move on to psoriatic arthritis?
Psoriatic arthritis.
How do you say it?
Psoriatic.
Psoriatic. I know it's funny, and I say
psoriasis.
Psoriasis. So I say psoriatic. I'm sure you're right.
I'm allowed to say I know I'm right.
Go on then, tell us about it.
So it's really simple. It's psoriasis in the presence of arthritis, or arthritis in the presence of psoriasis. So psoriasis, obviously, if you didn't know, is a skin condition which normally kind of flares up when, like, stress, illness. There's so many different types of psoriasis. But you see on people, like maybe on flexion points here on my forehead, and like red marks, but normally like elbows, knees, armpits, anywhere that flexes, backs of knees, and it can look similar to eczema, but you will see like red patches, and it can look quite sore. Not contagious, can I just say? Loads of people get embarrassed by their psoriasis because it can look unsightly, and people think, oh, I'm going to catch it. You can't catch psoriasis from touching someone's psoriasis. And I just want to say, like, obviously mental health is huge at the moment. Don't make someone feel bad when you see it. It's nothing contagious. It's something that they have to deal with. So be kind if someone does have psoriasis and you see it. So it's an inflammation, and you see red patches, like I've said. People normally have psoriasis and then it develops into arthritis, and it's caused when the immune system mistakenly attacks healthy tissue. They're very similar to rheumatoid arthritis, and which, again, it's not nice. It's not a nice one to have. Psoriasis can be very itchy, flaky, like dandruff all the time. Unsightly for some people.
In fact, we're running a clinic. I think we're running it in February with Adil Sherez around psoriasis, and it's a huge problem for many people. And you said the mental health issues, and I think there's some very frightening statistic, like 80% of people who have psoriasis also suffer at some point with depression because of it.
Yeah, because it's hard to manage, and because it's stress related. People, our lives are more stressful, so people are getting more flare-ups really quickly, and it's hard to manage.
How does it present then in the feet? Does it look like just? I don't mean just, but does it look like you've just got psoriasis on your feet? Yeah,
and then you get the arthritis, so psoriatic arthritis. But like I just said, you generally get the psoriasis first, and then if you then have arthritis, you get the it's called psoriatic arthritis. But you'll see the red patches on people's feet. They're like plaques. So rather than just hard skin, they're like plaques, and it might appear like, oh, I've got loads of hard skin, but actually they're really hard to debride. Like, you have to be really careful because you can easily make them bleed, because it appears really thick, but it's not really that thick. Ways of managing it is creams, moisturizing, keeping it nicely hydrated so the skin doesn't dry and then split because it's so dry. So you can get some good creams out there, really thick ones, like Diprobase, loads of things out there. You can get steroid creams, but like I said, you don't want to be using steroid creams all the time. Maybe just as a flare up to get it under control, and then go back to your normal foot cream or cream that you've been given, I would say things like E45 and aqueous cream are just not enough. You need something a bit thicker. That's another problem or complaint that I always get with foot creams or creams for psoriasis, is that, they're so thick and greasy. They need to be. Unfortunately, they need to be, and it's just something that people need to get over, so maybe getting into a good routine, half an hour before you go to bed, put it on your feet, sit with your feet up, put some socks on, so it doesn't stain your clothes. Or what I do, I don't have psoriasis, but when I cream my feet, do in the morning, and then put your socks straight on and put your shoes on. Put the creams in areas that are easy to find. So some people say put it in your bathroom next to your toothpaste. So whilst you're brushing your teeth, once you brush your teeth, you take the foot cream, you go and sit on your bed, put your foot cream and put your socks on.
And yes, because I mean, quite often people say that, isn't it? Cream your feet at night, put the socks on. By putting the socks on, presumably, or I don't know, is that not only is that sort of saving getting all your sheets all kind of greasy and horrible, but does it mean there's more moisture, it keeps more moisture in your feet? Do you think? I don't know.
Wearing socks creates heat, obviously, which creates moisture. So it does create moisture. Right. But I'm going to be honest with you, all the socks is doing is stopping your bed sheets getting dirty.
Oh, really?
Yeah. And I get people who go, I bought those moisturizing socks, and in my head I'm rolling my eyes. It's okay, but it's we do these little things to make us do things. So if the socks helps you to put cream on, keep doing it.
Absolutely. And I suppose psoriatic arthritis, I mean, psoriasis is an autoimmune disease, as is rheumatoid arthritis and all of those things. So that's why they're also closely interlinked. So, okay, so is there anything that we should watch out for, or anything else that you feel that we should add about the psoriatic arthritis?
No, it's a pretty simple one, really. It's not as complex as the other ones, but I think with psoriasis it's just moisturizing a lot. You see a podiatrist who can help you manage the hard skin, because it does come off, but obviously if it builds up, then it can be really, really painful.
Okay. I forgot to ask, if anybody wanted to add a question in the Q&A session at the bottom of the screen, please feel free to do so now, because I think we've now covered all four of those things. So please ask. And in fact, moving forward, I think we've suddenly discovered a bit belatedly that you can, when we get people to register, we can ask them to ask questions, which is probably a much easier way to do. So moving forward, when you register for a webinar, please have a little look. There will be a question box in there, so you can ask, because I know quite often, people can't make it to the webinars. We get a lot of people who register and then suddenly last minute can't make it. Great that we can see the webinars afterwards, but you haven't necessarily put your question in. So hopefully moving forward, we can do questions. So,
and as I always say, you can always contact me directly if you have any kind of things that you don't want to ask here, and I can get back to you with questions and answers. Brilliant.
That's really kind. So anything else we need to know? Other than the fact we know you're going to see the sun next week.
So are you?
Yeah, I am too.
Yes, taking a week off finally.
Yeah.
My birthday.
Right. I haven't had, there's no Q&As that have come in at the moment. If I have, I will absolutely post them on to you. Really lovely to see you again.
And you, thank you for having me again. And anyone who's come back to listen to this webinar, I'm glad I'm keeping you interested.
Well, and we'll see you again later in the year.
Yes, we're going to organise something for summer. So we'll make that nice and fun, and I'll try and be a bit more interactive if I can get a few props next time.
Yeah, well, no, you did well with the trainer. I think it was a different trainer from last time.
Always. I've got tons of trainers. I've got like 50, and they're all multicoloured like these ones.
Oh,
got a pink and black pair outside.
Really nice to see you, and thank you very much. Thank you everyone for joining. Bye.
Thank you.